Our lecture today is going to be about the complications of local anesthesia. So, when we see the complications, the word complication means any untoward effect. Okay. So, when we give a local anesthetic injection, we want numbness in a particular area of the body. For example, if we want to give an inferior alveolar nerve block, we want numbness or no pain or no sensation to be felt by the patient on that side of the mandible. So, this is the desired effect. But when we get any undesired effect, okay, as a result of the use of the local anesthetic drug, it is called a complication. And this complication could be due to the drug itself, or it could be due to the technique that we use. Okay, we are using an injection technique, so we could have a complication based on the injection technique also. So when we look at complications, we have both local as well as systemic complications. And this lecture is going to focus primarily about the local complications, which is happening at the site of the injection or near to the site of injection. So this is what means local complication. So complications in dental local anesthesia might happen when we administer the local anesthesia. And the first thing that can happen is a local complication in and around the site of injection. And when it happens in the whole body, we call it as a systemic complication, and that's not in the scope of today's lecture. That probably is in a different lecture. So today's lecture, as I mentioned to you, is about the local complications. So what are the different local complications that we can come across? Some of the commonest ones include needle breakage, prolonged anesthesia. The anesthesia normally lasts for 1 to 2 hours. If you give a lidocaine local anesthetic injection, it might last for an hour or two maximum. Especially if it's a block, it lasts up to 2 hours, but sometimes it is longer duration. So this could be due to a nerve damage. So again, nerve damage could be a complete damage or only a partial damage. So depending upon that, the anesthesia could be prolonged. And then you can have facial nerve paralysis. Okay, so you might be wondering how facial nerve paralysis, that too when you give local anesthetic injection, we'll look into it, how it happens. And sometimes we can have eye-related complications with the eye movements or eye closure. And you can have trismus meaning difficulty in mouth opening. Okay, so after injection, the patient starts complaining about difficulty in mouth opening. Soft tissue injury. So injury which in an area which is not desired at all. Like for example, you give local anesthesia in the cheeks and you do, like for example, infiltration in the maxilla. And then due to a cheek biting, the patient starts having soft tissue injury, which is inadvertent. So this is also a complication. So we can have a hematoma. Hematoma means a blood clot within the tissue. So normally when we have an injury, we have bleeding from that site, and then you can have a blood clot forming in the extraction socket or over a wound. But when there is bleeding within the tissues, okay, there is no external wound, but underneath the mucosa, if there is bleeding, or underneath the skin, if there is bleeding, it can form a submucosal or subcutaneous blood clot within the tissues. And this is what we call it as hematoma. Okay, so hematoma can also happen after a local anesthetic injection. And some minor complications includes pain or burning during injection. Okay, of course, the prick of the needle is always there. Okay, you can avoid it by using a topical anesthetic agent or a topical anesthetic spray or gel. But unusual pain or unusual burning on injection is also a complication. And sometimes when you don't follow a clean technique, an aseptic meaning you do not use sterile instruments or things like that, there is a risk of infection, there is a risk of edema and inflammation. And due to the local anesthetic drug in itself, you can also have sloughing of tissues. Sloughing is like ulceration. And also you can have post-anesthetic viral ulcers. So these are different complications that you could encounter after the local anesthetic injection, and this is specifically the local complications. So let us go one by one and discuss in detail the reason why it happens and how it can be prevented and what is the management, God forbid it happens. Okay, so 3 parts to any complication. Number 1, why it happens. Number 2, how it can be prevented. So a good thing about complications is when we follow a proper technique, when we follow the correct protocol, correct clinical steps, we could always avoid a complication. And that is the reason why we always try to emphasize on the fact that know your anatomy, know your technique, know your angulation, know the landmarks. So when we follow all of this, we could avoid these complications. Got it? So the first and foremost is needle breakage. So needle breakage happens as a mechanical injury. So it's like, the needle in itself breaks. So this is what really happens. And it more commonly happens with the nerve block techniques because you have a longer depth of penetration. So, the needle is inserted into the tissue for a very longer distance. For example, if you take the inferior alveolar nerve block, the needle is inserted into the mucosa almost like 25 to 30 millimeters. And whereas an infiltration, it is barely 5 to 10 millimeters. So the longer the depth of needle insertion into the mucosa, the greater the risk of needle breakage. Why it happens? When you use a thin needle. So this is one of the reasons why we have two different needles in our clinics. For the infiltration, we use a thinner needle, which is 27 gauge. And for the blocks, we use a thicker needle, which is 25 gauge. So when discuss about the instruments, I believe you would have reference to it that the bigger the number, the thinner the needle. Okay. So comparing 25 gauge and 27 gauge, the 27 gauge needle is thin. Okay. It's smaller in diameter compared to the 25 gauge, which is slightly larger in diameter. So anytime when we use a nerve block, we always prefer to use a 24 or 25 gauge needle. So anything thinner than that, there is a risk of bending and needle breakage. And second thing is like sometimes it's not practiced these days because we have been emphasized that in the protocol not to bend the needles. So in the olden days, they used to bend the needle for better access. So what happens is like when you bend the needle, you are creating a weak point on the metallic structure. So this can also lead to needle breakage. And the third thing is like any sudden movements, especially when you give a nerve block, imagine 25 millimeter of the needle is inside the tissues and then the patient suddenly moves. So this can also result in needle breakage. And the last point is what happens is like when you completely insert the needle into the tissues. So the weakest point they say in the needle is the hub. So the point where the metal attaches to the plastic. So whenever you insert the needle completely into the tissues, that is also a risk for needle breakage. And what happens when you inject it completely inside? So any movement, okay, any jerky movements, it can break or it can snap. And this is one of the reasons, again, we say that whenever we use a nerve block, we have to use a longer needle. And short needles are usually indicated only for infiltration techniques. So how can we prevent it? Okay, use a long, large diameter needle for any nerve block injection. And never bend the needle. Don't force the needle or forcefully move it once it is inside the tissue. And do not insert the needle into the tissues until the hub. Okay, so if you do it, you are calling for trouble. You are putting the patient at risk for encountering a needle breakage. And then observe extra caution when you inject in young patients who are very apprehensive, who are very anxious and afraid, immature or some mentally challenged patients, because what happens is like they might panic and they might jerk. For these kind of patients, apply good topical anesthesia, apply very good stress reduction protocol, keep talking to them, make sure that you have a good assistant to hold their head so that they do not move their head abruptly so that you will end up with a needle breakage. So what do you do if it happens? Okay, so we do not want it to happen, but if it happens, what do we do? So if the needle is visible, right, clinically, you should ask the patient first not to close the mouth, not to move. You can use a mouth prop to keep the mouth open. And then what happens is like you will observe the area where you give the injection. And even if you see a small amount of the needle projecting outside the tissue, you can use a grasping instrument, a hemostat or a needle holder to hold on to the needle and pull it out. So this is the easiest way. In case it is not seen, then probably what you have to do is like you'll have to refer the patient to a maxillofacial surgeon. And what they would do is like they will try to locate it using a radiograph and then remove it. So here you can see a picture of how sometimes it is so difficult to reach the needle inside the tissue. It is typically once the needle breaks in, it is typically like the needle in a haystack scenario. Okay, it's a small needle inside dense tissue. It's so difficult to locate. We may have to take multiple radiographs, and then sometimes even an external surgery is required to remove these needles. So the best way is to avoid these. The second complication is prolonged anesthesia or paresthesia. Okay, it is defined as persistent anesthesia beyond the expected duration. As I was telling you, normally it is an hour to 2 hours, but if it extends beyond that, then it could be called as a complication of prolonged anesthesia. Sometimes it could also be a transient or a temporary loss of sensation, and the patient feels numb for many hours or sometimes many days or weeks after the local anesthetic injection. And paresthesia means it is not a complete numbness, it is like an altered sensation. Okay, the patient feels that I feel like a numbness, but when you touch, I can feel it. So this is called as paresthesia. Anesthesia is complete numbness. Paresthesia is like an altered sensation. And this can also happen after local anesthesia. So why it happens? The main reason is when you give a nerve block, you are usually giving an injection close to the nerve trunk. Okay, so it's not just the nerve trunk, it's the neurovascular bundle. You have the nerve, the artery, and the vein, all three together going. Okay, so the injection is usually given close to this neurovascular bundle, which contains the nerve trunk. So if the needle accidentally pricks the nerve trunk, then you can have this paresthesia. Okay, so injection of local anesthetic solution contaminated by alcohol or any kind of sterilizing solution, this can also irritate the nerve trunk. And insertion of needle into a foramen, okay, especially for the inferior alveolar nerve block or the mental nerve block, we are always injecting close to a foramen. For the inferior alveolar nerve block, it is the mandibular foramen on the medial aspect of the ramus. And for the mental nerve block, it is usually near the mental foramen. So we have to exercise extreme caution when we are injecting. So, and this is the reason why when we give a nerve block, we always ask you to touch the bone. But once you touch the bone, you have to come back a little bit. Never inject close to the bone, because if you are injecting close to the bone, probably you are near the nerve trunk. So this can cause a paresthesia. And certain cases where you may not hit the nerve trunk, but you might injure the blood vessels surrounding it. And this can cause a hematoma. And the hematoma is a blood clot, right? So this blood clot can compress on the nerve trunk, and this can also cause paresthesia. So these are the multiple reasons how you can have a prolonged anesthesia or paresthesia after a local anesthetic injection. So how can you prevent it? Okay, so again, hitting the nerve trunk, well, it is not under our control because you do not see the nerve trunk clinically. You are not seeing it with your eyes. But what we say is, like, when you understand the landmarks clearly, when you know the technique clearly, the angulation, the point of insertion, and the small steps, like I told you, if you touch bone, you should not inject immediately. You should retract back and inject. Similarly, when you are injecting, before injection, try to aspirate. So if you are aspirating and if you get blood, we call it as positive aspiration. So in such cases, what you have to do is, like, you have to change the position of the needle. You'll have to bring it outside and then re-inject it. So the reason is, like, as I told you, the nerve always goes along with the blood vessel because it's a neurovascular bundle. So if you are into the blood vessel, then it is highly likely that you are injecting close to the nerve also. So these are certain techniques, the protocol and the steps that you follow to avoid this complication. And if it happens, how do you manage? In majority of the cases, probably even more than 99% of the cases, paresthesia or this kind of temporary loss of sensation is recovering normally. There is no need for any treatment because it is just an accidental prick or small slight injury or irritation of the nerve fiber. And this usually the nerve recovers faster. Very rarely you will have a permanent paresthesia, but again, due to a local anesthesia, it is probably so rare. I don't see many cases that are reported. Only reason is, like, probably there is some contamination of the local anesthetic solution or an expired local anesthetic solution which has been injected around the nerve, and then that has irritated, like it has caused a chemical injury to the nerve. So this could be a probable reason, but other than that, it's very rare for the nerve injury to recover, to not recover back. Okay, but important thing is, like, if your patient has a paresthesia or anything, you have to have a constant follow-up. You'll have to recall them probably once in 2 weeks for at least 2 to 3 months until their nerve sensation is recovered back. Facial nerve paralysis, again, this is also a very common complication associated with inferior alveolar nerve block. So any nerve block that you inject in the pterygomandibular space. So this is very much avoidable. Okay, you can avoid this complication. But let me tell you why this complication happens first. So if you look at it, this is your anatomy. Okay, so here you have the masseter muscle. Okay, the masseter muscle is on the lateral side of the ramus, and your injection is on the medial side of the ramus. So into the pterygomandibular space. Right behind the pterygomandibular space, we have the parotid gland capsule. So the parotid gland is a salivary gland, okay? And if you inject it into the parotid gland, nothing happens. But the problem is the parotid gland contains the fibers of the facial nerve. It has branches of the facial nerve. This yellow lines you can see, you have the branches of the facial nerve, and the facial nerve supplies the muscles of facial expression, okay? Blowing the cheeks, closing your eyes, smiling, okay, grinning. There are so many facial expressions that you do. All of this is controlled by these five branches of the facial nerve. So when you are injecting an inferior alveolar nerve block, if you go more deeper or if you don't contact bone, there is very high chance that your needle is inside the parotid capsule. And the parotid capsule is a tight structure. It's like a watertight structure because it is a salivary gland, right? So you don't want saliva to diffuse out of the gland often. So you have a very thick capsule. So if you inject into the parotid capsule, the local anesthesia diffuses through the gland and starts blocking the facial nerve impulses. So the facial nerve is a motor nerve. In most cases, anesthesia is given only for sensory nerves and never for motor nerves, because motor nerves are responsible for the body movements. Okay. So when the local anesthetic diffuses and blocks the facial nerve branches, you are not able to move the muscles of facial expression on the affected side. The side where you give injection, the patient will not be able to move their facial muscles. So the typical symptom is like they will not be able to wrinkle their forehead. They cannot close their eyes because the orbicularis oculi, this is the muscle of the eyelids, which helps in closing the eyelids. So this muscle will be paralyzed. And similarly, the buccinator will be paralyzed. So the patient will not be able to blow their cheeks. If you ask them to smile, their smile is deviated to the unaffected side. So all of this will happen. But again, this is only temporary because the local anesthetic action lasts for maximum of 1 to 2 hours. And after the local anesthetic is taken away by the blood, the facial nerve impulses are regained and the patient will recover back their facial muscles of facial expression movement. So after local anesthesia, you can have only temporary facial paralysis. Permanent facial paralysis does not happen. So remember that. So why it happens? As I told you, when you inject, especially the inferior alveolar nerve block, when you do not contact bone. So if you are contacting bone, 100% you are not inside the parotid capsule. So this is why one of the important steps in inferior alveolar nerve block, in addition to the angulation and the point of insertion, is like we have to go inside with the needle and touch bone. So once you touch bone, come back a millimeter and then inject. Okay, this is the steps. So if you don't touch bone and you are really deep inside the pterygomandibular space, then you are highly likely to be inside the parotid capsule. So this, how you can avoid, the answer is here. If you follow the right steps, make sure you have bone contact before inferior alveolar nerve block, you will avoid the facial nerve paralysis. So main thing is like by adhering to the protocol. But there is one technique, okay, one specific technique called as the closed mouth inferior alveolar nerve block, which is called as the Vazirani-Akinosi nerve block technique. So in this technique, it is indicated where patients have difficulty in mouth opening. They may have difficulty in mouth opening due to an infection, or sometimes they may have an abscess or something. They will not be able to open their mouth. So for a normal inferior alveolar nerve block, you need good mouth opening. But when you are not able to open the mouth, what you do is like you give along the same side of the ramus, okay, through the buccal. So you can just go into the textbook and read about it, okay, you will see the technique. So in this technique, this is called as a closed mouth inferior alveolar nerve block, or the Vazirani-Akinosi nerve block technique. In this technique, there is no way to touch bone. So you will go parallel to the ramus of the mandible. Okay, so normally we go in an oblique angle to the ramus of the mandible. That's why we touch bone. But here we go parallel to the ramus of mandible. So the needle is having a very high chance to go posterior to the mandible into the parotid capsule. So you have to exercise extreme caution when you use this technique. And this technique is usually used only by oral surgeons who are very well trained, okay, in using this technique many times. So whenever we do it, we make sure that we do not go more than 20 to 25 millimeter of the needle, okay, because we know that the ramus anteroposterior width is probably 30 to 35 millimeters. So we keep it well within that limit so that we avoid the facial nerve paralysis. So how do we manage? So first thing is like tell the patient, okay, don't worry, this is temporary. Okay, in 2 hours time, you will get your facial expression movements back. So here, this is actually a typical presentation where you see that the patient has inability to wrinkle the forehead on the left side, and when she smiles, you see it is deviating to the unaffected side. And also the patient is unable to close the eyes. See, she's trying to forcefully close the eyes. Only the right eye is closing, but left eye is not closing. So this is a typical presentation of facial paralysis. And since the eyes are open, you should ask the patient, in case they are wearing any contact lenses, please remove it because their eyelid movement is not there. Similarly, when the eyes are open continuously without closing, without blinking for a long time, there is a risk of injury to the cornea. The cornea is the outer covering of the eyeball. So what you will do is, like, you will manually close the patient's eye and put an eye patch and ask the patient to remove it after 2 to 3 hours once the facial muscle movements are regained backwards. Okay. And record it always. Documentation is important. So this is about facial nerve paralysis. So it happens only with the inferior alveolar nerve block and more commonly with the closed mouth technique. And in the open mouth technique, if you are able to make sure bone contact, then you can 100% avoid it. Ocular complications, meaning complications related to the eye and the eyeball movements. So sometimes even visual disturbances have been reported. This is one of the rare complications. Personally, I have given thousands of inferior alveolar nerve blocks and other nerve block injections and infiltrations and local anesthesia. I have not come across this complication, but you need to be prepared because a rare complication can happen maybe once in 10,000 times, but still you need to be prepared why it happens, how it happens, and how to manage it. So they say that it more commonly is seen with two techniques, usually which involves deeper injection. Okay, number one is the Gauge mandibular nerve block, where you inject close to the mandibular condyle. So this is called as the trigeminal third division nerve block. Okay, and the other technique is called as posterior superior alveolar nerve block, or this is also called as the tuberosity block or the high tuberosity technique, where you inject posterior to the tuberosity. So this is usually for the maxillary nerve, which is the trigeminal second division nerve block, or the posterior superior alveolar. So because the point of injection within the tissue is almost very close. So only two techniques. Number one is Gauge technique. The second technique, either the tuberosity or the high tuberosity technique. So these are the techniques which are more commonly associated with the ocular complications or eye complications. So let's see why it happens. The reason why it happens is, in this area, you are usually giving it close to the infratemporal fossa and the pterygomandibular fossa, the pterygopalatine fossa. And in that area, you have the stellate ganglion. Okay, the stellate ganglion is a ganglion which sends sympathetic supply, autonomous innervation to the eye. So when you inject close to the stellate ganglion, you block the nerve impulse transmission through the stellate ganglion. And sometimes you could also inject close to one of the arteries which is supplying the eyeball. So usually if you look at the maxillary artery divides into branches which give the one for the maxillary teeth and the maxilla, and also it has an infraorbital branch going upwards. So when you inject in one of these arteries, the local anesthetic solution can diffuse through the arteries and go and reach the orbital cavity or things like that. And also intravenous injection when you inject it into the blood vessel. And very rarely you will also have a direct trauma to the periarterial sympathetic plexus. You know, the sympathetic supply to the eyeball usually happens around the arteries. So you could actually injure that one. The main reason is the stellate ganglion. When you inject close to the stellate ganglion, that is when you can have the ocular complications. So the complications which the patient may complain include, visual disturbances. They are not able to see clearly. They have blurring of vision. They have double vision because the muscles which control the eyeball movement become paralyzed. Sometimes the patient can have tearing from the eyes. Tearing is like, the tears that is coming from the eyes. And they are not able to accommodate, so when they see bright light or dark light, usually the pupils accommodate and adjust so that they are able to get the right amount of light going into the retina. So this accommodation issues can happen. But again, overall, it's a rare complication. But if at all it happens, these are the symptoms you might come across. So the only thing is, like, as I told you, any complication that involves local anesthesia injected into or near a nerve, it's temporary because the local anesthetic effect is there only till the solution is near the nerve. Once it is removed by the blood, it weans off. So you can always tell the patient that it is just temporary. So please don't worry. So first thing is reassuring the patient. And to give more confidence to the patient, you can always take an ophthalmologist consultation, and the affected eye should be closed, and then the patient transferred to the ophthalmologist. So this is the management of this complication. Trismus, okay. So trismus, the word trismus meaning a difficulty in opening the mouth. Okay. So basically what happens is like you have spasm of the muscles of mastication and the patient is not able to open the mouth properly. So they are not able to open the mouth when they speak. They are not able to open the mouth to chew food. So when you try to forcefully open the mouth, the patient feels severe pain in the muscles of mastication, namely the masseter, the medial pterygoid, the lateral pterygoid, and everything. Okay, so trismus can happen due to two reasons. One, it could be due to an infection surrounding the muscles of mastication, or it could be due to injury to the muscles of mastication. So when we give any local anesthetic injection, okay, in and around the muscles of mastication, which usually happens during the inferior alveolar nerve block or the posterior superior alveolar nerve block in the maxilla. So what happens is like we can injure the muscles of mastication, namely the lateral pterygoid or the medial pterygoid. Or what happens is there is a bleeding which causes a hematoma, and this hematoma undergoes infection, and this infection irritates the muscles of mastication, and the patient develops trismus. And another thing is like whenever you give an injection, if you do multiple needle pricks close to the muscles of mastication, this also can injure these muscles or irritate these muscles, and the patient can have a pain and trismus. So how you can avoid it is like use a sharp needle, and it should be sterile so that you do not take in any bacteria and cause infection. And third thing is like after one or two penetrations, the needle should be disposed and take a fresh needle. So when you do that, you can avoid the pain that is occurring due to multiple penetrations. So this is to avoid trismus. And the second thing is like properly care for and handle dental local anesthetic cartridges. You know, the dental local anesthetic cartridge should be used well within the expiry date. It should not be allowed to get contaminated with other solutions. In the olden days, what they used to do is like in order to keep it clean, they used to immerse all the dental local anesthetic carpules into alcohol. So if you are immersing it in alcohol, it has to be cleaned thoroughly before you start using it in a local anesthetic syringe. Otherwise, you can have alcohol contamination within the local anesthetic solution, and this can cause irritation of the nerve or the tissues around the injection. Use an aseptic technique. Okay, an aseptic technique is a sterile technique. There should be no contamination, no bacterial contamination. You should not touch the needle with bare hands. The needle should be untouched by the bare hands or any tissue until it is injected into the patient's tissues. Practice the atraumatic insertion and injection technique. Okay, so this is how you do an atraumatic technique is like you have to insert the needle into the tissue at a perpendicular angle. Okay, so if this is the tissue, you have to make sure that it is entering the tissue at around a 90-degree angulation. So this way you have a precise needle insertion or injection without much pain. Avoid repeated injections, avoid multiple needle penetrations into the same area, and use the appropriate amount of local anesthetic solution. Don't use excessive solution, because if you use excessive solution, then the patient again can have pressure injury, or you can cause a hematoma in that area. So what happens if you have a patient developing trismus? So identify the cause. Okay, so first thing is like rule out whether there is infection or not. So usually with infection, the patient will have severe pain. You can see redness in that area. There is inflammation. Sometimes you can even have pus collection in that area. So if there is an infection, then you may have to give an antibiotic. Otherwise, if there is no such infection signs, there is no swelling, there is no pus or anything, it's just simply an inflammatory episode. So you can give anti-inflammatory medication, which is the painkiller medications. Additionally, you can also prescribe muscle relaxants. Muscle relaxants are medications which help in breaking the muscle spasm. Another thing that can help is hot fomentation. You can give warm compress on the area where the patient complains of pain. So this will also help in enhancing the mouth opening. With that, you can also ask the patient to do physiotherapy, which is mouth opening and closing exercises. So every time they open and close, they should try to open more than what they did before. Like for example, they have to measure it. First time, if they are opening 10 millimeter, so after a few hours, they should try to open up to 12 millimeters, then 15 millimeters, then 20 millimeters, like that. So this way, you can train them for physiotherapy and ask them to open their mouth properly. The next complication is soft tissue injury. Okay, soft tissue injury does not happen directly because of local anesthesia. It happens either due to improper instrumentation, which is highly unlikely because whenever we handle the instruments, we see where we are placing the instruments. So usually not much of a problem. But one of the common problems or common causes for soft tissue injury is patient without their knowledge, they tend to bite their soft tissues. So this happens when you give local anesthesia, and the local anesthesia anesthetizes or makes tissues numb not only in the area of treatment but also surrounding areas. For example, you give an inferior alveolar nerve block for a 4-6 tooth extraction. The 4-6 is anesthetized. Along with it, the lip, the tongue is also anesthetized, right? So you do your extraction and you send the patient home. And imagine that the patient is not well aware and they start biting their tongue or they start biting their cheek because they do not feel any numbness. So what happens is once they will realize that they have been biting their tissues without their knowledge, only after the anesthesia goes away. So this can be avoided. This complication can be avoided by educating the patient, telling them that, see, you have had an inferior alveolar nerve block anesthesia for the lower molar extraction. So after the anesthesia is over, almost up to 2 hours, you'll still have the numbness. And if you bite your tongue or lips, you will not feel any pain. So try not to do it. Okay. So if you try doing it, then you will end up having severe soft tissue injury. So this is how you educate the patient. So normally adult patients are easy to educate and are very much aware of it, but children, it's difficult. So you have to have the parent or the teacher or whoever is the caregiver for that kid to make sure that the kid is not biting their lips or tongue. So in fact, some of the kids, what they do is like in the pediatric dentistry clinic, after giving anesthesia, before sending the patient home, we put a sticker on their forehead or on their on their shirt or t-shirt saying that, hi, I've had anesthesia, please let me know if I'm biting my lips or cheek. So such kind of stickers or bracelets can be given so that the anybody who sees the kid biting their lip or cheek, they can ask them to stop it. So this is actually a sticker. Okay, so you can actually put a sticker on the t-shirt or on the forehead so that they do not bite it. And you can also avoid it by putting a cotton roll. Okay, especially if you have a patient who is adult, who's mentally challenged, so their milestones are not good and they are not able to understand whatever you instructions you give them. So then probably you can put a cotton roll like this so that it avoids them or prevents them from biting. And management, if at all it happens, you'll have to give analgesics and antibiotics and then apply petroleum jelly so that the healing happens. And if it is too much severe, you may even need to give antibiotics to help it heal. Next one is hematoma. Okay, hematoma is a bleeding or a clot that forms underneath the tissues, underneath the skin or the mucosa. So basically, it occurs due to effusion or bleeding from the tissue blood vessel into the extravascular spaces and can happen due to inadvertent or accidental injury to the blood vessels. And also, it is more likely to happen in a area where the tissues are loose. So, for example, if you look at the the mucosa, the cheek and the lips are having loose tissue, a lot of loose tissue. So it is more likely to happen in these areas than in the mucoperiosteum where it is very tightly adherent to the bone. Okay, so this is how it happens. And one of the commonest nerve blocks that causes hematoma in the oral surgical armamentarium or the oral surgical clinic is the posterior superior alveolar nerve block. So here we give injection behind the maxillary tuberosity in the pterygopalatine fossa. And in the pterygopalatine fossa, we have a rich collection of blood vessels called as the pterygoid venous plexus. So the pterygoid venous plexus is a collection of multiple veins. So any accidental injury into one of these veins can cause severe bleeding and it will cause a hematoma. So this hematoma typically has the dumbbell-shaped swelling where you see a swelling above the zygomatic arch and below the zygomatic arch. Okay, so if you want, you can actually go and see the PSA nerve block hematoma or the pterygoid venous plexus hematoma. You'll see a lot of images. And it happens as a result of the venous puncture. Okay. Similarly, in the inferior alveolar nerve block, so when you give the nerve block, if you inadvertently nick or injure the neurovascular bundle, that is also when you can have a hematoma in that area. So possible complications of hematoma include pain. Okay, you can have pain, and since it is a blood clot, It can undergo infection and it can irritate the surrounding tissues. So patient can have trismus also. So what is the management? So first thing is prevention. So when you know the correct anatomy, you can prevent it. And what you have to do is like whenever you use an injection technique close to an area which is rich in blood supply, has many blood vessels, use a thinner needle, use a short needle which is thin, so that you do not injure the blood vessels, and minimize the number of needle penetrations, because multiple needle penetrations, the greater the risk. So when you are able to do it within one or two needle penetrations, then you are able to reduce the risk of a hematoma forming. And once inside the tissues, don't try to move the tissue needle here and there. Okay, so when you're trying to probe within the tissues, then it can accidentally cut the blood vessels, leading to a hematoma. So when you see the swelling, okay, after hematoma, usually the most common clinical presentation is the patient starts swelling without any injury, and you can see a redness also, like in the previous picture. So here you can see the patient has a redness with a swelling, and when it is in loose tissue, okay, you can see severe redness like this, okay, and this usually happens 1 day after the hematoma forms. So if you are able to see it clinically, start applying pressure over that area. So applying pressure can reduce the size of the hematoma. Second thing is you can apply cold pack. Cold pack will cause vasoconstriction and it will reduce the bleeding at the site of the hematoma. So this is the immediate thing that you can do. So within the first 6 to 12 hours, applying pressure and cold pack helps a lot. And after that, if there is a hematoma, if you still see the swelling, you should ask the patient to apply warm packs. So first one is pressure, second is cold pack, but this will help you only for the first 6 to 12 hours. After 24 hours, after the first day is over, then you can ask the patient to apply warm packs in that area. Second thing is like if you have a patient who is immunocompromised, patient is having diabetes or any other medical illness, the hematoma can get infected. So you give them antibiotics. But if you have a healthy patient, there is no need for antibiotics. Give them only analgesics, and it will help in removing the hematoma and the symptoms of pain and trismus associated with it. The next one is pain on injection. So, as I mentioned to you, normal injection always causes a pain, but sometimes you can have an unusual pain or burning sensation. So, this mainly is due to a careless injection technique. So, you have you are not taking care about stretching the mucosa or not giving good topical anesthesia. This can cause pain. And usually remember that the palatal injection is very painful because the mucosa is tightly adherent to the bone underneath. So this can also cause. Another thing is like you can have a blunt needle. So if you have used a needle to touch bone once, then you have to immediately replace that needle, because the moment you touch bone with the needle tip, the sharpness goes away and this can cause blunting. Sometimes the needle can also bend at the tip, causing what is called as a barb. So these kind of barbs can tear the mucosa or the tissue as they are injected or as the needle is penetrated through the tissues, and can cause severe pain. So how we avoid it is like using sharp needles, using fresh needles. If you have done multiple needle penetrations, you should change it immediately. If you have touched bone with your needle tip, you have to change it immediately. So these are the ways you can avoid it. Another way of preventing pain is using the local anesthetic solution at the right temperature. So if you have taken it from a refrigerator, don't use it immediately. Let it come down to room temperature by keeping it on the room for a substantial amount of time, or you can warm it. Okay, so this is a way of how you can actually bring it into the room temperature. And a new technique which has still not come across in all the carpules, but experiments are going on, wherein what they do is like they buffer the local anesthetic, because in most cases the local anesthetic solution is slightly acidic. It has a pH less than 7, but the body fluid pH is around 7.4. It's slightly alkaline. So whatever you do, you cannot match the pH or to the body fluid, pH of local anesthetic solution to the body fluid, except by adding an alkaline solution to it. And this is what we call it as buffering the local anesthesia. A buffered local anesthetic solution has a pH which is almost close to the body fluid. Okay, it's almost like 7.4. So when you give a local anesthetic solution with a similar pH of the body fluid, then you have a better acceptance. The patient does not have pain or stinging sensation at the time of injection. So this is one way of avoiding the pain during injection. So burning sensation, again, this happens mainly due to the local anesthetic solution. So if you have a contaminated solution or an expired solution, then you can have burning sensation. And more acidic solutions, local anesthetics with epinephrine, okay, they are more acidic than those without epinephrine. So these kind of acidic solutions should be injected very slowly, because if you try to inject forcefully, it starts irritating the tissue around the site of injection, and this can cause the burning sensation. And again, buffering will also help here. If you buffer the local anesthetic to make it pH 7.4 or close to pH 7.4, this will be reduced. So right now, here we do not have the buffered local anesthetic cartridges, but in the US, there are certain local anesthetic cartridge delivery methods that are available, which also help in buffering the solution. Infection, as I told you, this happens mainly if you are not following an aseptic technique. Okay, an aseptic technique means that you have sterile needles, no bacterial contamination in the area, not injecting into an infectious area. You have an abscess, you should not inject in that area. So when you try to avoid these things, you can always avoid infection in that area. So say mainly you can see that contamination, improper technique, injecting into an area of infection. This is the causes why you can have an infection after local anesthetic solution, after injecting a local anesthetic solution. So when you use sterile disposable needles, you have proper handling of the needles, and then proper care of the local anesthetic cartridge, you can avoid the infection at the site of injection. Additionally, what you can do is like not only using sterile needles and cartridges, you can also disinfect the area of injection by asking the patient to do an antiseptic mouthwash. So using a chlorhexidine mouthwash can also help the patient. And management, so if you are able to identify, so usually the infection symptoms are not seen immediately. It happens only after 24 hours. So if you see the patient coming and complaining to you of pain and redness at the site of injection, then probably it is a sign of infection. And what you have to do is you have to start the patient on antibiotics and analgesics to help reduce the pain and the infection. And most cases, a 5 to 7 day course of antibiotic will be required to avoid any complications. Similarly, as to infection, you can also have edema and inflammation. But for infection, you need to have an aseptic technique. But even with an aseptic technique, you can have edema and inflammation. Excuse me. So basically, this is due to the injury at the site of injection. So how you can avoid it is try to use a sharp needle, a fresh needle. Don't do multiple needle injections or needle penetrations. And try to use the right amount of local anesthesia. Know your landmarks very clearly. Use a topical local anesthetic agent so that you are avoiding pain during injection. So proper care and handling of the local anesthetic armamentarium using atraumatic injection technique, trying to inject perpendicular to the tissue surface. This is the atraumatic needle injection technique. And when it happens, you can always give the patient analgesics, which will help in reducing the pain. Sometimes warm compresses also reduce pain, but warm compresses should not be given on the day of injection or pain, but usually the day after. So it is 1 day after. So this is how we manage infection. Sloughing of tissue is like a kind of ulceration, and this happens due to prolonged irritation or ischemia. So what happens is like there is epithelial desquamation. Okay, so this is due to topical anesthesia being applied on the gingival tissue for a very long time. So when you apply the topical anesthesia, it should not be applied for more than 20 to 30 seconds. But when you just leave it there for a minute or two, the concentration of the local anesthetic and other chemicals in the topical anesthesia can irritate the mucosa and can cause death of the mucosal cells, and this will cause sloughing. The epithelium is completely removed. There is also another instance where you can have epithelial desquamation. This is called as a sterile abscess. When you inject a vasoconstrictor, certain solutions contain norepinephrine as a vasoconstrictor, which is very potent in the area of injection. So when you inject norepinephrine in a soft tissue site or for local along with local anesthesia, this causes vasoconstriction of the blood vessels around the site of injection and causes necrosis. Severe vasoconstriction leads to no blood supply and necrosis, causing an abscess. And more often, this sterile abscess or sloughing of tissues is commonly seen in the hard palate than on any other sides of the oral cavity. How to prevent it? Topical anesthesia, don't apply it for more than 20 seconds. Um, and what you can do is like reduce the contact of any of the local anesthetic to the bare mucosa. And when you use vasoconstrictors, do not use high concentration vasoconstrictors. The prescribed is 1 in 100,000 or 1 in 80,000. Don't go less than that. Okay, if you use 1 in 50,000 or 1 in 30,000 solution, so these kind of vasoconstrictors are highly concentrated and cause the sloughing or sterile abscess. Post-anesthetic intraoral lesions. So these are again pretty rare. So this happens due to two reasons. One, it could be due to stress related, or it could be due to reactivation of a underlying viral infection. So in both cases, you can have vesicles or ulcers in the mucosa. And this definitely is not under our control. But if it happens, so that is, I mean to say, it's like there's no way to prevent it, but you can manage it. So how you can manage it is like you can ask the patient to apply topical local anesthetics or topical steroid gels. Okay, so Kenalog gel is called as Kenalog Ora base. So this can help in the rapid resolution of these ulcer lesions. And also topical local anesthetic mouthwashes like viscous lidocaine or magic mouthwash. These can be used, and this will help in reducing the pain symptoms for the patient. So this is about the different local complications of local anesthesia, and it has been sourced from the reference textbook, Stanley Malamed's Handbook of Local Anesthesia, the 7th edition. And if you have any doubts, you can reach out to me through the group leader. He can send me either an email or text me. I can help you out.